Someone's not on mute, just as an FYI. Okay. Can you all see my screen?
Yeah.
Okay, perfect. So this is case review 28. This lady is a Gravida 2 Para 1. She had a previous SVD in 2019. She is asthmatic on inhalers, appendectomy, BMI of 20. Anomaly scan showed placenta reaching the os. So she was rescanned at 32 weeks where the placenta was anterior high, normal fetal growth, Lycor and Dopplers. And just to sort of note, she was anemic in pregnancy. So she came in at 39 weeks, contracting, sort of 1 to 2 in 10, low risk. I don't think she had a CTG done in triage. So she was sent home. She came back in again at 39 weeks with query SHROM, and there was no SHROM was confirmed. As far as we know, no Lycor was seen, and I think the ROM plus was negative. So she came back in at 40 plus 4, which was the 5th of the month, saying that she's been irregularly contracting over the last 4 to 5 days. This is the CTG you see when you walk into triage. And this is the second half of it. So she's been cannulated, and some IV fluids have been started. Anyone want to hazard a guess the plan?
What was the gestation?
40 plus 4?
Okay, and baseline was around 140 in the previous slide?
Yeah, about 140, 150.
Okay, fine, and she's contracting.
Yeah.
It looks like on the second one, it picks up a little bit.
Yeah.
Movements?
None were reported in this trace.
Okay. So they're thinking the fluids will help the variability, which is 100% definitely going to happen.
Well, this is what I say on every single review, isn't it? Fluids go up because they're going to fix absolutely everything. But they were put up. She was obviously cannulated and bloods were taken, and the idea, I think, was transfer over to labour ward, and then she was going to be examined over there, and then a plan was going to be made on labour ward. And the consultant at this point was also present. So the trace ends at around 21:03, and then she's transferred straight over to labour ward. This is still the 5th of the month. Blood pressure is normal, pulse 91. Pre-meds were given at 21:08 in view of the reduced variability and the possible need for transfer. And then at 21:10, she was examined and found to be 2 centimetres dilated. An ARM was performed, and there was concerns of evolving hypoxia on top of chronic. That should have said, sorry, gradually evolving hypoxia on top of chronic hypoxia. Anybody want to agree or disagree with that one?
Isn't it either, we say it's either chronic hypoxia? If it's chronic hypoxia, how can it be gradually evolving at the same time?
So I think, Indra, the kind of rationale behind this one was that obviously if you look at this, you've got a raised kind of baseline for gestation, arguably at 150, 145. Mm-hmm. So you'd expect it to be slightly lower. So you've got a raised baseline for gestation, you've got shallow decelerations, however, they are alongside the contractions, but they're chemoreceptors, and you've got reduced variability. So if you were to, so if you were to look at this on its own,
I would say chronic hypoxia.
You would say chronic. I totally agree with you. And I think the kind of the rationale behind it was obviously this looks very, very chronic. It continues, however, it starts to sort of pick up and look a bit better. It looks like we're kind of getting a micro, what's the word? kind of getting a magnifying glass out, but that looks like a possible variable decel at the very end there, sort of at about 2101. But we've had what looks like a chronic hypoxia that looks to be improving. And when she's taken over to labour ward, obviously, as you can kind of see, the variability does increase, but you can see that the sort of deceleration towards the end of the trace here looks like it's getting wider and deeper. And I think that was the kind of rationale behind why this could have been a gradually evolving hypoxia on top of the chronic. However, it's not something that I've ever sort of seen written down or anything before. I don't know if we've got any obstetricians that can sort of shed some light. I don't know if Mr. Gibbs on the call, or I think Dagmar had joined us.
Yeah.
What are your thoughts?
So by definition, actually, chronic hypoxia is something that you would like to kind of find out before you go into labor, because it's literally that you're saying this baby's unfit for labor. So chronic hypoxia is something that evolves over time. So if it happens really over weeks, over a long period of time, then you have an increased base rate. So it's essentially you have reduced growth in glycogen kind of stores because the baby can't store. You have essentially a reduced growth, but that is only the case if it's happening early on for relative placental insufficiency. So late onset placental insufficiency doesn't have a reduced growth. And then you have essentially on the CTG, because of the centralization of the baby, the absence of accelerations usually is the first thing. Then you have a relative tachycardia, which is the increased base rate. You have potential absence of cycling, because the idea is there's adrenaline in the system, so therefore the baby doesn't sleep, but that's only the case if it happens over a short period of time, because obviously if it's a long period of time, then the baby still needs its resting periods. No, it would still go through that. So therefore there's a difficulty with the faster onset or slower onset one. And then you have with any further stress to the uteroplacental flow, because the majority of decels are placental issues, not necessarily cord compressions. Then you have essentially decelerations, then they tend to look shallow because this baby is already firing and can't essentially sustain any further difficulty to the placenta providing, no? Because they are big and they are entirely dependent on the oxygen and pretty much the glucose of the mother. And hence the NOT flow inhibits this. So does this CTG fulfill that? Then the answer is no, but it might have significantly reduced uteroplacental reserves, or they're called RUPI, relative uteroplacental insufficiency, and they evolve signs of decompensation or evolving hypoxia very fast, right? So, but at the moment, no, I can't see anything that is a definitive, can't go for labor, but I do agree that the base rate is higher. So what are the other alternatives for this? With a query previous SHROM, and but here we see ARM, so there's nothing that indicates water leak or infection, but I would screen for that. Maternal pulse rate is okay, so it's surrounding the baby, but at the moment I have no reason that I think I can't go for labor, because there's cycling and there is essentially a still normal base rate. But I do agree with you, Cara, that this baby probably doesn't have the best reserves, but you do not know until you try if it tolerates labor, yes or no. Sorry, lengthy answer, but I hope that explains the rationale.
No, that's perfect. Thank you, Dagmar. So she was ARM'd at this point, and then the consultant came to review at 21:45 and reported that the CTG had sort of begun to normalise. So the plan was to sort of continue, keep a very close eye on it. And then on the next slide, as you can see, Primo's obviously given him in sort of anticipation of the need to move to theatre. But yeah, and then IV paracetamol was given because she was in quite a lot of pain at this point. Went out to the toilet at around 22:20, and at 22:30 the fresh eyes was done with the midwife and CTG was classified as normal. Don't know whether I would classify this one as completely normal, given the idea of possible chronic and the sort of previous history, if you like. But I guess if you were looking at this more so the first sort of half of this CTG, you could argue that. But given the sort of history, we'd probably go with more suspicious in this point. And yeah, as you can see, we're getting some sort of chemoreceptor decelerations towards the last sort of 10 minutes here. CTG continues.
Just a quick question actually there. You mentioned that you classify the CTG as suspicious. We're still only 2 centimetres, so we're still classifying intrapartum, or are we going to classify as antenatal?
Yeah, that's a good point, actually. I think because the only difficulty you've got there is there's such a massive grey area between people being 4 centimetres and not, and whether or not that's in labour, because technically we've given her an ARM. So we've now started off the process of like induction and whatnot. She's not classified as intrapartum as per, you know, your sort of nice guidance and whatnot, but we've initiated her labour to continue. So antenatally, you definitely classify this as an abnormal CTG, given the chemoreceptor decelerations that you're seeing.
Perfect, thank you.
Cool. So we continue. Bearing in mind the baseline, so baseline started off at around 145, 150, didn't it? So we're kind of stable. Our variability is good here. We are getting some decelerations with our contractions. Anybody want to rush to do anything major? No, I'll continue. What about now? Okay. Blood pressure is retaken and it's 90/56, and her pulse remains at 95.
Is there any documentation of position of baby if it's OP?
No. No abdominal palpation was recorded.
She has significantly more decels and a lot of loss of contact. So in order to know what's going on at this point in time, I would really like to have better monitoring, especially as this looks as if this baby doesn't have brilliant reserves. No, it's a higher to start base rate, and it's you know, it's quite literally that each and every one of the uterine activities has, if the base rate is indeed 160 here, a kind of response from the baby that indicates that the placenta has its difficulties. So clip, please.
Okay. So she was feeling pressure at 0035, so at the very beginning of this segment. So she was examined at 0040 and was found to be 4 centimetres dilated. I should mention, actually, and I completely forgot to mention this at the beginning, from what I had described of this night shift it was pretty hellish, and the unit was incredibly busy. I think they had something like 6 one-to-one care cases on labour ward at this moment in time. So just be aware of that when we're considering the human factors element of our CTG interpretation, because, yeah, I was asked to it will make more sense a little bit later, because I'll show you what was happening in the room next door. But yeah, so obviously at around 0051, we have this very lengthy deceleration here. It looks like our baseline has almost certainly risen up to sort of 150, 160, and we've got this very large, sort of almost 3 minute long, if not 3 minute long, deceleration here. I think the emergency bell was pulled at this point, if not the one after, and the registrar came in to review and found this lady to be 5 centimetres dilated 15 minutes later. Anyone got any suggestions as to what would happen, what should happen next?
Taking into consideration if the unit's busy, then midwife in charge is probably busy as well. So just being aware potentially might need to use Tributin if she's sort of cracking on quite quickly. But in regards to CTG, it's still got good variability. Your baseline has risen, so you've probably got signs of gradually evolving. But if you have to sort of take into consideration the unit and what else is happening, it would be potentially worth having Tributin in the room just to consider slowing down the labour if we are concerned, if theatre's busy, etc. So sort of taking that sort of situational awareness of what's going on.
Yeah, absolutely. I only forgot to mention that, so oops. But yeah, so you are absolutely right. So Tributin was given at 0102. This is your CTG now, and obviously at 0115 we've started another litre of Hartmann's because that is going to fix all of our problems. Baseline here, not really sure if I can determine one. When it comes to sort of determining your baseline, you want at least sort of 3 minutes at the sort of same level, but as you can see, really difficult. We've still got good variability, which is our reassuring factor that this baby's brain is still functioning well. But how long can this go on for? It doesn't look like, I would say either, that the Tributin has had much effect on this woman, considering we would normally expect it to have made some changes by 20 minutes. And actually what it looks more to me like is that we've got longer, deeper chemoreceptor decelerations towards the end of the tray, so well after that 20-minute period. Any recommendations?
So what exactly is the plan at this point? Have they done a V? So the V that was done before now, how long ago was that? Sorry.
Infection in mum.
Pardon?
Hello? The V that was done before this one, the last V you said was 5 centimeters. How long ago was that? Sorry.
That was at 1 o'clock, only 15-20 minutes ago, Emmanuel.
20 minutes ago.
Yeah.
Yeah. So at this point, are they busy in the other room? Because if they've given Tabutaline, given 20 minutes, and things are not getting better, what's the plan? Are they going to deliver this baby?
So that is the plan, to hopefully deliver this baby. But what they did next was they gave a second Tabutaline within the sort of half an hour. At 0148, the emergency bell was pulled and she was moved onto right lateral position. We're quite lucky that this baby sort of settled itself out towards the last sort of 10 minutes of the CTG, but they were waiting for a delivery of a different client before they were able to transfer her to theatre. I don't know if anyone was there from this call at the time that this was going on, but I'm pretty sure at this point they were doing a Kiwi at almost the exact same time. So they were doing that
in theatre, actually doing a section on someone else.
Oh, it was a section. I couldn't remember whether it was a Kiwi or if it was a if it was a cesarean section. But I think at this point the CTG was shown to the registrar whilst she had another woman's abdomen open, because obviously we were trying to escalate the sort of severity of the situation. The fact that 2 Tabutylines has not had much of an impact on helping this baby to rest, this baby's baseline to sort of settle down, anything like that, and is clearly not having an impact on this lady. You know, she at this point she would need to be transferred for delivery. But what can you do when you've got one registrar who's performing surgery on somebody else?
Did anyone notice maternal pulse here? Did we do an ECG, or is there a reason why maternal pulse is under 30?
No. I mean, we know that sort of Tabutaline can cause maternal tachycardia, but yeah, significant increase. Not really sure. No sort of septic screen was performed or anything like that. And the only observations that I've got are the ones that you've seen. So the last set of obs were done at midnight, and we're now at sort of 2, so an hour and a half later, and no obs were really recorded. No temperature was recorded either. I think, thinking again about our human factors, the likelihood was that this midwife and whoever was supporting her at the time was most likely focusing very, very much on the CTG element of the care and not so much on making sure that the woman was sort of stable as well. But also understanding that terbutaline could have had an effect.
But if you kind of go back, Cara, the timing of the maternal tachycardia is pretty much coinciding with the terbutaline. So I would at the moment not kind of jump in a square about that. So, and I think it's also important to clarify what are the effects of terbutaline. No? So it does not necessarily reduce decelerations. It only does that if the kind of time in between is enough for the placenta to do its perfusion. No, so because it essentially spreads decelerations out, because it spreads uterine activity out. So it was prior to the terbutaline 3 and 10, and now it's 2 and 10. But they're long, and if that is essentially too much work for the placenta or too much impairment of the work that the placenta does, that's the only place where the gas exchange really happens, no? So whatever else the kind of baby has in reserves, so then you still don't make decelerations necessarily flatter or shorter. It always depends on the impact, and I think the other question that is always important to ask is, if terbutaline doesn't work the first time round, why?
Yeah.
Yeah, because there are other drugs that can be used. Yes. So I mean, I have no idea. I didn't hear that she's on labetalol, because obviously it's an alpha beta blocker. No? So it can counteract terbutaline. It's the same receptor that it works on. So the question is always, why? What makes the contractions, because it also doesn't counteract an infection, and it doesn't counteract an abruption. So but I hope, given that that wasn't mentioned, that was clinically ruled out before a second dose of terbutaline was given.
Yeah. Yeah, absolutely. Okay, so I think the transfer occurred at the very end of the CTG, and then she was transferred to theatre. So at 02:10, she arrived in theatre. At 02:18, the spinal was put in. And then at 02:27, the emergency buzzer was pulled. Very quickly after, knife to skin and knife to uterus and delivery occurred.
I have a question. Do you know what her blood pressure was when the spinal was sighted?
It was normal when it was sighted. I'm not sure what it was after it was sighted. But that's exactly what my thought process was when it comes to our sort of bradycardia that's about to occur here. Based on the fact that she's now been sort of lied flat. She was in right lateral before, and the CTG kind of did pick up a little bit, looking a bit slightly more normal, and then all of a sudden the spinal's gone in, and it's almost immediate actually. If you think 02:18 is exactly when that deceleration starts to occur, so very much likely due to the spinal anesthetic and the lying down, the position change of the mother that's caused this deceleration.
Well, the lying down would be rather helpful, but any kind of perfusion is based upon flow and volume. No, so it's essentially vascular resistance and volume. If you kind of lower the blood pressure with the kind of medication that you give during a spinal, you quite literally take the ability for the placenta to perfuse away. More so in kind of women that have hypertensive disorders, but they quite literally crash. So for any anaesthetist, if you have them in your CTG kind of sessions, the head anaesthetist in Kingston was actually kind of really interested, and he held many talks. I'm not an anaesthetist, so I can't comment upon that, but I found it was incredibly insightful to kind of see what he essentially does regarding spinal anesthesia to avoid any blood pressure effect, and that there are far less kind of this crashes towards the end. So it's quite amazing how big the impact of anaesthetist can be for obstetrics. Yeah.
Thank you, Dagmar. Does anybody want to guess the APGARs or the gases?
Sorry, just a quick question, Dagmar. What did the anesthetist say? Because I mean, this is a quite frequent occurrence each time they do the spinal, and then you get to have this. Maybe you are scrubbing, and then you get to hear, "Oh, cat one, come back quickly. The CTG is becoming terrible. Come quickly, come quickly." This happens too quite often. Is there something like a trick that he said that he can do that maybe other anesthetists can learn from?
Yes. Yes is the answer. So A has to do with the position that they're in. So many anesthetists sit women up for kind of spinals. The answer is don't do that. It's essentially all of them can be done in a lying position. You can use slightly different drugs. You can essentially kind of ensure that the vascular dilatative effect of the kind of drugs during the spinal can be counteracted so that you have minute or no blood pressure drop. So and if anesthetists, and they do that all the time, yeah, that's quite literally what they do when they give drugs. They are incredibly good with physiological monitoring. But unless you emphasize upon that, and that is where this multidisciplinary team learning comes from, then they might not be doing that, because it has to do with awareness. So confront your anesthetist with kind of looking how many of the cut twos you converted into cut ones in theater. And then let them themselves essentially audit how many blood pressure drops they have. Because honestly, it's all out there. I'm not an anesthetist, and if I know that, I only tell the anesthetist, please watch, no blood pressure drop. So anything from positioning to Miradol, no, slightly kind of different drug, and I'm always kind of bad with names, but I can send it to you, is what they can potentially kind of give to epinephrine is not so good regarding vascular. If it depends on if there's hypertensive effects, but they do that. No, we don't need to. So, but they can essentially kind of keep the blood pressure absolutely unaffected from spinals, and that then means it prevents this.
Thank you. Thanks. Yeah. Obviously, the awareness of that, I think, and the discussion with probably the anesthetist, and if he knows what to do to keep that blood pressure at least stable while you're getting scrubbed, maybe that kind of discussion probably will help to prevent this kind of thing happening too often.
Yeah, the talk, I think Andrew Tan is also kind of happy to share. He's the kind of anesthetist in Kingston that held CTG kind of MDT talks and CTG masterclasses, right? So just kind of ask him if you would like to share it. So because he's very kind and approachable. Yeah.
Okay.
Dagmar, if you would be able to send me his email or something, that would be, or if you're happy to ask him if that's okay, that would be amazing.
I have.
Yeah, I think that would be great, so that we can probably tell our anesthetists if they're interested in.
I'm not
if there's any trick to be like.
If I have any kind of more good contacts, I can ask via Ahmed, because as you know, Kara, I'm at the moment.
Yeah.
I know not necessarily in England and not working for the NHS anymore. So therefore, all my nice accesses were gone unless I saved them. So I have to look. Yeah.
Thank you.
Yeah.
In terms of APGARs and gases, what are we expecting from this baby?
I think.
I mean, I will hazard around maybe 7.1 ish, because I mean, from when the rapid deceleration started happening to delivery was less than 2 minutes. So I think there was no massive concern about the baby before they delivered the baby. But yeah, we'll see. I mentioned it.
Thank you, Emmanuel. This baby clearly had better reserves than we expected. Abgars of 9, 10, 10, arterial pH of 7.24, base excess of -5, and a lactate of 4.9. And then venous pH 7.32, base excess of -5.9, and a lactate of 4, which I think was really good. I just want to show you what was going on in the room next door at the time. So this lady was, this lady was a gravid of 4 para 2, previous Kiwi in 2018 and an SVD in 2020, BMI of 27, wear and tear, back problems, ex-smoker, low risk pregnancy. Her anomaly scan was completely normal, and that was the only sort of care that she needed in her pregnancy. She was brought in via LAS for abdominal pain at 38 weeks, vomiting for 2 days, reduced movements, antibiotics for a chest infection, so she was admitted, and she remained an inpatient for 2 days whilst having IVs and nebulizers. Apologies, I don't have any of the CTGs for you from that period of time. But as far as I'm aware, baseline was normal for gestation, and all of the Dawes-Redman criteria was meeting. When she was obviously out of abdominal pain, but that was probably due to the vomiting rather than actual uterine issues. On the 6th, she came in at 40+5 via triage contracting, was found to be 4 centimeters dilated at 0027. This was her CTG. Now, just first of all, bearing in mind this lady is a very low risk pregnancy, other than obviously her chest infection at 38 weeks, is that really a reason that we need to start CTG monitoring? No, I believe the birth centre was shut this night, obviously due to staff being transferred over to labour ward and whatnot, but she didn't necessarily need a CTG in labour, despite the fact that she was on labour ward. So this is your monitor. She's cannulated at 0108 and sat upright, and it appears that they're getting slightly better monitoring in her position being in that position. Sorry, jumbled words. At 1:15, her blood pressure was 125/88 and her pulse was 73. At 1:27, she shrum clear Lycor, and the position was changed to left lateral. And then at 01:38, an FSC was applied. So just note the time frame. This is going on in one room, exactly the same time that the delivery was going on in another room. And also, I think, while the registrar was in theatre performing a cesarean section.
Sorry to disturb. What time was she 4 centimeters when she came to triage? Was it 12:30?
Sorry, yeah, 12:30.
12:30, 4 centimeters, and this is her CTG an hour later.
Yeah.
Right. Okay.
What do you think, Pay?
There's a lot that I'm thinking right now, but I think I'm just going to let you continue for now.
Anyone want to try and sort of classify any type of hypoxia or make any comment on this one? Anyone want to make a plan?
Looks like she's
It's virtually
looking-
impossible to classify.
Yeah. I was going to say she's a para 2, so we're leaning on the fact that she's a para 2 that she'll just crack on. Is that
I think
another...
Yes and no. Bearing in mind you've got your obs reg is in theatre. This is in one room. In the other room we had the previous case. Let's just say the sputoline was on high flow on this particular night. An FSC was applied just due to the immense loss of contact. When the FSC was put on, I think she was actually the same. I think she was still remained 4 centimeters at this point, although it's not very well documented. So yeah, and then what kind of hypoxia?
Well, the CTG starts off bad. It's reduced variability. I would say either chronic hypoxia based on the fact, but there's no raise in baseline. I was going to say chronic based on the fact that the CTG starts off bad, but it could also be subacute. I don't know if I would say gradually evolving, because it's all. I don't know. Correct me if I'm wrong, guys. Sorsha.
Can you go back?
Which other doctors do we have? Dagmar?
Can I just see the kind of bit? Right, so you have a lot of loss of contact. Difficult, no? So because chronic hypoxia is always increased base rate for gestational age, kind of absence of accelerations, but she's contracting, so that can be fine. It's reduced variability in absence of cycling, and it's shallow deceleration. So I can't see shallow decelerations, but there is so much kind of loss of contact that it's difficult to define. I would have initially said 140s, you know, I would compare it to previous one, seems to be okay. But yes, please put an FSE on. And the moment, the bit before the FSE on the next page, and then after that, it looks like gradually evolving. And usually if babies are chronic, they quite literally can't throw kind of good deep decelerations anymore because they literally have nothing to give. But they are deep, no? So they go down to 60 beats per minute, but the variability in between looks essentially okay. So compensated, but there is very little time that the baby spends on the base rate. So you have, if you would cover each and every deceleration, so the question is how much does it spend on the base rate and how much is it down, and then you are heading towards subacute. So she seems to be contracting a lot, and subacute reduces the pH relatively speedily.
Yeah. So this was my thought process, was the fact that all of this loss of contact appears to be when we're either having contractions and when there's a possibility that we're having decelerations. Given that, I'd go with there's a possibility that this is a subacute hypoxia towards the last sort of 10-15 minutes of the CTG, although difficult to determine based on the loss of contact. And yeah, obviously we know that the pH drops 0.01 every sort of 2 to 3 minutes within a subacute hypoxia. So we're going to need to do something about this. Tebuteline was given at 0142, and the CTG appears to sort of recover, if you like. Lots of sort of variable decels, but yeah. And then the registrar was available and became present at this point. Decision was made for instrumental, and delivery happened within sort of 15 minutes after this.
Why an instrumental? Because it looks better.
That's a good question. Not quite sure what the rationale behind that one was, considering she's obviously a multiband fully. But I think also given the fact that the lady in the room next door, which was the previous case that we saw, needed to be delivered. I think there was a case of we can't leave this CTG looking like that for much longer, and the possibility of when the tebuteline sort of wears off that it does become subacute again. So yeah,
I can answer that question, Cara.
Go for it.
So the rationale was, even though she's a para 2, she was not pushing. No matter how much support you gave her, she was not pushing. So given the fact that the other lady in the other room needed to have a CTG like an hour prior, it kind of, the reg said, well, she needs to make a decision and make her mind, because we did actually do a small trial of pushing with the woman and her pushes were not effective. So yeah.
Right, thank you, because evidently you have to take the full situation into account. And if you think that, you know, no matter what you do, you can't get her to either chill out for a moment or eventually push, because she wouldn't have to need to push, no? So because as the kind of CTG goes better, essentially you can also make her comfortable. But if all of that is being tried and there's no improvement, then yes, you have to kind of manage your labor ward.
Perfect. Thank you, everybody. This baby was born in fantastic condition, I believe. APGARs were 9, 10 and 10. Unfortunately, no cord gases were obtained for this one. I'm not really sure of the reason why. However, I'm going to assume the human factor element comes in here. And those are our cases for this week. Does anybody have any further questions or anything?
Yeah, sorry, just a question about, is there you say you don't know why the cord gases were not done here. Did we ask?
Did we ask what, Emmanuel?
About whether why the cord gases were not done? Did we ask? I mean, did we get any feedback from?
No, this was no. Because
for medical legal reasons, with this kind of CTG, I think it's good to have those kind of things so that if it was an oversight, I mean, it will be something that, next time, whoever it is will know that, please, it needs to be done, that kind of thing, basically to just feedback to that person.
Oh, yeah, absolutely. I mean, yeah, I will ensure that I feed back to the midwife that was on this case. We have a very similar issue, Emmanuel, on an almost daily basis, whereby people either forget or they don't realise, or they assume that when babies are born with APGARs of 9, 10 and 10 that they don't need to do cord gases. This is something that, I try my very, very hardest to sort of combat on a regular basis, but there's only so much one person can do. I think that there's a possibility that we might get to a point where we take cord gases for every single delivery, just to try and stop this sort of thing from happening. But yeah, you're absolutely right. From a medical legal perspective, not being able to obtain them or have them present is going to be an issue further down the line, or it could be.
Sorry, Cara, can I just mention something that happened actually? We've had a lady that came into triage 36 plus week with a good history of STROM, GBS positive. And on her pad, there's a slight tinge of green. But because it wasn't completely soaked, her history was she had a good pooling of lycra at home, a big gush. We did a speculum and an amnisure, which came back negative. But the woman's history, even giving her our pad, still had MEC on it. And, I'm thinking of the first presentation, that woman came in with queries from amnisure was negative. And after discussion with the registrar, looking at the history of the woman and her, GBS positive, this query MEC now, decide to do an induction to reduce the risk of chorio. Just to, I don't know, be aware that sometimes, I don't know if the amnisure is not as accurate as we think they are.
No, absolutely. Yeah, no, 100%. I say this in every single study day that I do, in that we rely on technology an awful lot, which is great, and it really helps us with our interpretation. Like, where would we be without CTGs, in my humble opinion? But at the same time, we've got to try and take our own clinical judgment into it, but also understand and listen to what the women are saying to us as well, because that could have been a case where she'd SHROM quite early, and then we've missed out on providing her with the care she needs just based on a little line on a test.
True, very true.
It's difficult.
Just to back that up as well, we had a case where which woman was reporting green discharge at Croydon as well, and it was similar sort of history. And I think we have to note the fact that if anyone's coming in with green discharge or query MEC STROM, but we can't confirm the STROM, still treating her with green discharge is abnormal. So it's not just assuming it could be STROM. It's actually green discharge can also be an indicator of something, an infection, etc. So it's not just focusing that sort of task orientation to STROM, but also it could be something else as well. With this case, unfortunately, the baby died, but it can be something else. So I think we really have to be aware of that.
Yeah, for sure. For sure. Okay, everyone, any other questions?
Hi, Kara.
Maybe.
Yeah, so I was just thinking about this issue of cord gases. Could we raise it in the Take 5, and also we ensure that at the beginning of the shifts, the midwives in charges are aware which people are having the cord gas access, especially on night shifts, because maybe those are some of the factors that could be affecting. Because if you are having an emergency, I'm sure the coordinator and 1 or 2 people should really be involved to support. Because if you are the one in theater looking after the baby, you will be too preoccupied to think about the cord gases. But if your second midwife is around, she's the one who will be taking care of you of the cord gases.
Yeah, I mean, we've mentioned them on numerous occasions in Take 5. Numerous what's the word? Key messages have gone out about this.
Yeah.
Like I've kind of lost count. I've created posters and put them on every single surface on labour ward, and I go around and I do them myself an awful lot of the time. Unfortunately, B, there's only so much you can do.
Yeah.
Do you know? But yeah, absolutely, we can definitely mention it again and again and again.
Yeah, because like Emmanuel says, some CTGs like the ones we have seen, you won't like to be the midwife standing to answer legal about why you didn't do cord gases. And maybe that time you'll even never remember why you didn't do them, even if there was such a good reason.
Yeah.
Maybe the machine was not working, for instance, or something like that. But if it is not indicated the reason why it wasn't done, then we have no leg to stand on.
Yeah. Yeah, absolutely.
I'm sure.
I think what's probably one of the problem, a lot of midwives, especially we've got a lot of midwives, especially at nights, who are agency and they have no access to the cord gas machine. And only a few people cards seem to be working. I don't know if that could be one of the factors that's causing this problem.
Yeah, there's going to be a lot more training done for cord gases as well, because a few of us in the education team have now become the trainers. So I know that there's a lot of people that don't have access, not just the agency, but our own staff. So yeah, we'll get round to making sure that's happening for everybody.
Yeah, thank you, because that goes back to the accountability of you as an individual.
Yeah. Yeah, absolutely. Okay, thank you, everybody.
Thank you very much, Cara.
All right, I'll see you all next week.
Thank you.
Thank you.
Bye.
Bye.
Socha? Sorry, Socha? I think she just went. Cara, can I just ask you a question?
Yeah.
I've never heard, and I do not know if that essentially kind of went out correctly. More than 2 weeks ago, I think we had the discussion about chemo receptor mediated decelerations, and I mentioned that I would be very careful phrasing it like this because there isn't a deceleration that isn't chemoreceptor related. And Socha had asked for the article. I think I passed it on, but I'm uncertain right now because.
Do you know what? You almost certainly have, Dagmar, but yeah. I can't stop sharing my screen. I don't know what's happening. Where is it? Okay. But I've been locked out of my emails for the last